So hello friends and welcome to my channel. So today we'll be discussing about the mitral valve prolapse, which is generally known as the MVP. So this MVP has many different names. I've listed some of them here. So it is also known as the systolic click murmur syndrome, as the Barlow syndrome, as the floppy valve syndrome, or as the billowing mitral valve leaflet syndrome. So these means the one that is the mitral valve prolapse or MVP. So the MVP is most common in the females of age 15 to 30 years old. However, the incidence is also in the older people of age greater than 50 years old, but then the incidence is only in the men, the most common. Okay, so there is also familial incidence seen in the mitral valve prolapse, where the autosomal dominant form of inheritance is seen. Okay, so MVP varies from the symptoms as well and from the structural changes. So some of the patients may have only the systolic click and the murmur with mild prolapse, where some of the patients may have severe mitral regurgitation. So the systolic click and murmur with the mild prolapse is due to the posterior leaflet, whereas the severe mitral regurgitation is due to the chordal rupture and the leaflet flail. So this is the most common abnormality leading to the primary mitral regurgitation. MR here means the mitral regurgitation. So moving to the next, the cause of MVP is still unknown, but in many of the patients it is genetically determined. Okay, so many of the patients are asymptomatic and they remain asymptomatic entire their lives. So the symptoms of MVP is arrhythmias. So this is the most common ventricular premature contraction and the paroxysmal supraventricular and ventricular tachycardia. So there is basically arrhythmia seen in the MVP patients plus atrial fibrillation. So this may cause palpitations, lightheadedness, and syncope. So the patients generally has arrhythmias resulting into palpitations, lightheadedness, and syncope, which generally increases upon exertion. So sudden death, however, is rare in these patients, but this may occur in patients with severe mitral regurgitation and depressed left ventricle. I'll just note it down here, but it may occur in patients with severe mitral regurgitation and depressed left ventricle. So on auscultation, a mid-late systolic click is heard. Which is why it is also known as the click syndrome. So this mid-late click, systolic click usually occurs for about 14 seconds or more after S1. So this systolic click is thought to be generated by the sudden tensing. I'll write it is generated first by sudden tensing or because of the elongated chordae tendineae. Or due to the prolapsing of the mitral leaflet. So when the patient has stress or there's a lot of exertion or physical activity, there can be sudden tensing or elongated chordae tendineae, and then there is prolapsing of mitral leaflet, which may result into the mitral regurgitation. So which is why the systolic click is generated. Okay, so this systolic clicks may be multiple. It may be followed by a high pitched mid-late systolic murmur, which is best heard at the apex. So I'll just note it here, best heard at apex. And this is followed by the high pitched mid-late systolic murmur. And this systolic clicks can be multiple as well. Okay, so this systolic click is radiated. So the radiation of the systolic click depends on the leaflet that is involved. So it depends on the leaflet that is involved. Okay, so I'll just draw the classification here. So if if there is the involvement of the posterior leaflet, and if there is the involvement of the anterior leaflet, which means if there is the posterior leaflet prolapse or if there is the anterior leaflet prolapse, so there is a jet of murmur. Okay, so this jet of murmur will then be classified into two. So if there is the involvement of the posterior leaflet prolapse, then the murmur will be anteriorly and it will be radiated to the base of the heart. So I'll just write it here, radiated to base of heart. Whereas if there is the involvement of the anterior leaflet, then the jet of murmur will be posteriorly and the murmur will be radiated to the axilla, and at the back. So there is the radiation of the systolic click or the murmur. So this depends on the leaflet that is involved. So if the posterior leaflet prolapse occurs, then the jet of murmur will be anteriorly and the murmur will be radiated to the base of heart. Whereas if the anterior leaflet is involved, then the jet of murmur will be posteriorly and it will be radiated to the axilla and the back. So it is just opposite. So be mindful of this. So moving to the next, that is the myxomatous degeneration. So this is generally in MVP, this myxomatous degeneration is confined only to the mitral valve, even though there is the tricuspid and the aortic valves may also be affected, but generally the myxomatous degeneration is confined only to the mitral valve. I will just note here that also the aortic and the tricuspid valve is also affected. Okay, so generally posterior leaflet is the more commonly affected. Most common is the posterior leaflet. So there can be valvular regurgitation as well. So this is generally caused by the rupture of the chordae tendineae. I will write as in the short form. CT here means as chordae tendineae, and there is progressive annular dilation and calcification. Progressive annular dilation and calcification. So this results in the valvular regurgitation. So not every patient will have the regurgitation. Some may be asymptomatic, some may have the mitral valve prolapse, where they will have the palpitations on exertion and exercise, but some of them may have regurgitation due to these 3 points, that is the rupture of the chordae tendineae, or due to the progressive annular dilation, or due to the calcification. So on laboratory examination, so we generally do the ECG, where ECG in most of the patients is normal, but it also may show the biphasic or the inverted T waves, may show biphasic or inverted T waves in leads second and third. Okay, so MVP generally is a systolic displacement of the belly of the mitral valve leaflet. So I'll just mention it here. It is the systolic displacement of belly of mitral valves. So there is this displacement of the mitral valves by at least 2 mm in the left atrium. In the left atrium. So this is one of the important points. So there is the systolic displacement of the mitral valves at least 2 mm into the left atrium, which causes this prolapse and the regurgitation. So this prolapse can be of the both leaflets or of only one leaflet. Of both leaflet or of only one leaflet. So next, the treatment. So infective endocarditis prophylaxis is indicated for the patients with a prior history of endocarditis. Also to relieve the chest pain and to control the palpitations, beta blockers are given. And if the patient is symptomatic from severe mitral regurgitation, then mitral valve repair is indicated. So this was all about the mitral valve prolapse. So I have discussed about the causes, the structural defects that is caused in the mitral valve prolapse, also the laboratory examination, and about the treatment of the mitral valve prolapse. So that was all. So thank you.